This is the 15th topic in our ongoing free continuing education series. It's also our 8th symposium using the Children's Minnesota Education and Training System for credit. Children's does require you to set up an account on their learning site to receive your education credit. This will have several benefits for you. It will provide your certificates much faster than you have gotten them in the past. And when you create an account, it gives you access to all the continuing education on their site, which you can also take a look at and see if there's anything else that you're interested in for credit there. Children's Minnesota also issues EMS credit, so EMS providers can get their CEUs in the same way as other registrants, physicians and nurses, APPs. That means faster response time for EMS clinicians as well. EMS clinicians can still watch together as a group using one registration link. No worries, just make sure that you email a list or a roster of your attendees to your state EMSC program manager by end of day Sunday so we can provide your credit. By the way, no need to put your name in the chat. Like webinars sometimes ask you to do, Zoom will keep a record of both your attendance and your viewing time. We won't take a scheduled break tonight, but please step out if you do need one. Before we move into our presentation, I wanted to tell you a little bit about the folks who bring you these symposiums. These symposiums are a product of your state EMSC program. EMSD stands for Emergency Medical Services for Children, and it is the only federally funded program in the country dedicated to helping emergency care providers give the best care for kids. Each state and territory in the U.S. has an EMSC program that is funded in all or in part by a grant from the federal government. Our group is called the Heartland EMS for Children Coalition. We're a group of Midwestern EMS for Children managers from Iowa, Kansas, Minnesota, Nebraska, North Dakota, and South Dakota. And we've kind of banded together to maximize our impact and share our ideas and our resources. There are several behind-the-scenes members of our team who are working really hard for you tonight. They are Kjelsey Polzin from Minnesota, Chettie Greer from North Dakota, Regan Blackwell from Nebraska, and Corolla Lauck from South Dakota. Kansas EMSC is also a member of our group, and their EMSC program manager position is currently unfilled. These pediatric symposiums were born during the pandemic from a lot of discussion about how best to bring you affordable continuing education. Since September 2020, we've offered 50 hours of free continuing ed for EMS providers, physicians, nurses, APPs, and more on topics like burns, poisons, healthcare, special healthcare needs, human trafficking, provider resilience, youth suicide. I could go on. I also want to let you know that all attendees are in listen-only mode. Your mics and your webcams have been automatically disabled. If you have technical difficulties, you need support, or you just have a comment, please use the chat box and we will respond as we're able to. If you have questions that you'd like to ask our speakers at the end during Q&A, please type them into the Q&A box and we'll get to as many of them as we have time for. Finally, all attendees must be present for at least, and I need to see what the slide says on this, 90 minutes and complete an evaluation to receive continuing education credit. Once the symposium is complete, you can access your Children's Minnesota account site, fill out the evaluation, and get your credit quickly. If you don't sign into your Children's Minnesota account right away after we're done, you'll also get an email about completing your evaluation. Your certificates can be found in your account after the evaluations are received. Please print them or save them for your records. You do need to complete those evaluations within 30 days and claim your certificate to receive credit. After 30 days, you won't have the option for credit. So 30 days from today. As always, reach out to your state program manager if you have any questions. This slide is our contact information. We'll also show it at the end of our presentation if you have any questions. Some information about accreditation and how we do that. These are our disclaimers, our Children's Minnesota disclaimers, and we have no disclosures. first presentation. Assessing pediatric patients can be challenging. We don't see them as often. Their vitals can be different from adults, and depending on their age, they might not be able to tell you what their complaint is. Meanwhile, we know kids tend to compensate really, really well until they don't, and then they fall apart. And it's enough to make even the most seasoned medical person say a prayer at the beginning of each shift not to see a pediatric patient. I hear that a lot. It's tempting to try to memorize some algorithms to help us remember everything we need to do to assess them. But what about those patients that don't present the way the books say they will? Tonight, we're going to talk about how to assess pediatric patients and how to move beyond the cookbook to honing that special spidey sense that guides us in figuring out a particular patient who may or may not fit the algorithm. Our first speaker is paramedic Con Olson. Con is a regional executive director for TECS Inc., based in Holton, Kansas. TECS provides emergency and non-emergency ambulance service in 4 counties in that state. He has more than 25 years of experience in volunteer and career-based EMS, as well as communications and fire service. His topic is entitled Rapid Assessment of the Pediatric Patient. Now I'll turn things over to Con. Welcome, Con. We're glad to have you.
Thank you. It's a pleasure to be here. It's a great program, and I'm glad to be able to share some thoughts tonight, and just kind of lead a discussion around. And so please feel free to put your questions in the Q&A session so that we can kind of get through them as we go through the evening. So get my slides shared here. Are you able to see my slides?
We are.
All righty. Not too much of a lag there. That's a good thing. So I will leave my camera off for a little while we're going through this, just so I don't have any slowing of the process. So, but feel free to throw your questions into the Q&A and we can kind of go from there. Of course, yes, it is EMS week, and I always take this portion of my presentation to thank my staff. Without all of them, I wouldn't be able to have the time to go and do presentations and discussions and education and a variety of other things that make EMS click behind the scenes. So I've moved pretty much into an administrative role. Occasionally I am on an ambulance if things have gotten really busy in our system or somebody needed a quick break to just kind of relax after a busy day. But I do try to get out there a little bit and run calls periodically with the crews, but it is really them who are out there every day. A little bit about our organization. Like she said, we operate in 4 rural Kansas counties, 2 of which do not have hospitals in them. The largest one has a population of about 17,000. So collectively between those 4 counties and our interfacility and critical care divisions, we'll see somewhere in the neighborhood of 10,000 contacts over the course of a calendar year. So they are really the ones out there working to help our patients. And we work with a lot of first responder programs out of the nearly 30 fire departments that we interact with. All but one are volunteers. So we really try to work on the education component with them as well as with our own staff to try to integrate them into one common system. So I think that's really a key is you cannot operate in silos and you have to be able to have a seamless transition. For some people that comes very easy. Other people, when I go deliver presentations, and I find that the silos are very well built and very tough to crack through. So that's one of the very first keys that we have to get across is being able to interact with each other all the way from the public education through the 911 center and EMD process through first response programs and the transporting agency and on into the emergency department. So the standard no conflicts of interest, anything that we discuss as far as products and medications or devices are purely for a discussion purpose, and always refer to your local protocols and whatever your state or regulatory agencies allow you to do or not to do has to take precedence. So be sure to follow that thought process as we go through the evening. My job tonight is probably best described to stimulate a debate or some discussion. Get you to discuss, maybe even disagree. I would imagine there will be several of you that disagree with some of the thoughts that I want to share tonight. And it's not that I think one way is better than the other. I think it is a good chance to stimulate some discussion and get you to think outside the box and realize that we've always done it that way forever and ever is not necessarily the best thing for advancing evidence-based medicine. The other objective tonight is try to get you to think that kids aren't scary little creatures out there. So with that being said, like I say, there may be some conflicts in presentations. There may be something that you don't necessarily align with, and that's fine. It is really just a chance for you to start that internal debate on how we can do things better as a system. How can we be better prepared to handle those critical pediatric patients? And that's really what I want tonight to be about, is for you to start that debate yourself, and maybe even take it back into your organizations and have that true discussion at the table about what you're doing well, what you're not doing well, and learning on some ideas that can help advance some evidence-based medicine in your systems from start to finish, and have better outcomes. Because EMS has historically done some things that over the years we thought were good ideas, but evidence and outcomes told us otherwise. So it's trying to develop those changes, and sometimes change is hard for some people, but this is the time to start that debate. Some of you were probably told by your parents that you should have been lawyers because you can debate or argue very well. Some of you may have been in a debate program in school. So as we go through tonight, try to take both the affirmative and the negative aspect of it and try to figure out how we can improve as a system overall. So typically, we find people that are in one of two categories when it comes to running pediatric patients. Some people love it. Some people can handle it very well. Some people are used to it, especially if they work in a predominantly children's-based system. Other people probably fall into some humorous little anecdotes of, I don't want anything to do with kids. They scare me. And please don't let me have that call. Like you said earlier on, they say that little prayer at the beginning of the shift. I don't want a pediatric patient. So I will warn you, as I go through my presentation, at times we will probably talk about some things that are fairly difficult. This is kind of a bullet point highlights of a much larger presentation that I do. So I probably won't take a lot of time to get down into a lot of great detail. However, that doesn't change the fact that sometimes that subject matter is a little bit difficult. Or as we go through things, sometimes it triggers a bad call that someone has had, and that's okay. If you need to take a few minutes to step away, please do so. Sometimes we've all got those skeletons in our closet of calls that have left us a little scarred over our career, and it's okay to acknowledge those things and to realize that is going to be a part of what is now your new normal in EMS, as opposed to what it was before that particular call came in. So I always throw that warning in there that sometimes we will be discussing some difficult issues. If you're paged to a 65-year-old in cardiac arrest, a lot of us do that on a frequent basis, at least once or twice a year, if not more frequently than that, depending upon how busy your system is. You've practiced that ever since EMT school or maybe even EMR classes, let alone the number of times as an advanced provider you've probably run that scenario in a classroom or actually out in the field. It's some of those things that come second nature to you. You can recite the algorithm up one side, down the other, front and back, and have no problems getting through it. The tones go off, your heart rate jumps just a smidge, cardiac arrest, big call, important. Adrenaline gets up pumping a little bit, but you know what you're supposed to do. If I changed that to a different alert and tell you this is now a 1-year-old in cardiac arrest, things change in your mindset. And that's where I really want to start with tonight, is adjusting the provider mindset that kids aren't scary creatures. And we'll get into some points of debate here to help promote or try to disprove that thought. But at the same time, you can't not acknowledge the fact that that changes your perspective when you hear a pediatric call, whether it's a trauma, whether it's an arrest, whether it's a choking, whether it's a seizure. Something that is a life-threatening event gets your attention, and the fact that it involves a child doubles that adrenaline rush that you're going to experience. Cardiac arrest for the 65-year-old, that's system one. You can do that in unconscious thought. Like I said, you can recite the algorithm up one side and down the other. You can just walk in, do it, run it, and do the very best you can. System two thought process is a lot different. It requires you to slow down. It requires you to take a second to take a breather and realize, hey, this is something I have to think about. Problem is, you're in this rush situation with a life-threatening child. You have upset family members, upset bystanders. First responders may also have their adrenaline running wild, and that compounds everything and creates an additional distraction for you. So how can we better prepare for that? It takes time, it takes repetition, it takes practice, but it can be done. And also know there's some shortcuts, there's some safety features that you can throw in to help calm you so that you can calm everyone around and still provide fast, quality, safe care to that child in a life-threatening situation.
With 1380, I understand your emergency. Let me know when you want to go in.
Yeah, we have a part of the aircraft issue, so we're going to need to slow down a bit.
Southwest 1380, speed at your discretion. Maintain at any altitude above 3,000 feet.
Southwest 1380, we'd like to start turning it down.
Southwest 1380, start turning southbound there. There's a Southwest 737 on the 4-mile line. Will be turning southbound. Start looking for the airport. It's off to your right and slightly behind you there. And altitude is your discretion. Use caution for the downtown areas.
Okay, could you have the medical meet us there on the runway as well? We've got injured passengers.
Two passengers, okay. And is your airplane physically on fire?
No, it's not on fire, but part of it's missing. They said there was a hole and someone went out.
So that comes to what I want to point out as the system one process. It is certainly not something that people rehearse for, but that repetitive what to do in an emergency for Captain Schultz as a naval aviator and her career as a commercial pilot allowed her to remain calm in a frantic, sad, terrifying situation for everyone on that plane, which is the process you have to bring in when you come into a situation where you're dealing with kids that are critically ill or critically injured, and you have everyone turning to you to look and say, help this child. What do we do? It is the point where you need to step in, step up, and help take control of the situation, get everyone's nerves under control, get their adrenaline calmed down, comfort the family, provide quality, safe care for that child. So that brings us to a point of debate. Are kids little adults? Yes, they are. No, they aren't. That debate has reoccurred over the last couple of years in what was probably a well-meaning statement many years ago about kids not being little adults. And I'll grant it. You approach them differently. Equipment size is different. Interactions are different. Vital signs are different. But from the protocol standpoint, look at the cardiac arrest algorithm. Look at the seizure algorithm. Look at the respiratory algorithm. While doses are different, while equipment size is different, don't let the fact that this is a child confuse you or throw you off your game, because really, when you get right down to it, there's not a lot of difference in the protocol itself. Airway, breathing, circulation, EKG monitoring, vascular access, oxygen is needed, pharmacology is needed. You just have to be able to have the right equipment size, the right doses, and that can help bring you under control while you're getting ready for this patient. So I'll let you debate that internally, which side of that fence you land on, because there are positives and negatives to both sides of that. Yes, they are. No, they aren't. I think that was, like I said, a well-meaning thought process or statement many years ago, but the wake effect of that is it's helped reinforce some nervousness in providers, especially providers that fortunately don't run kids a lot, let alone very critically ill or injured kids on a regular basis. So that in and of itself raises your anxiety, let alone the fact that you may have a connection to this child of some way. Maybe they look like your kid or grandchild. Maybe, we operate in rural communities. These are the same kids when we see them on the ambulance that we've seen them do tours when the school comes down and goes through the ambulance. We see them at our kids' ball games. We see them growing up inside sports. We see them growing up inside the school musical or at church or at the grocery store. So you start to develop that connection with these kids. So whatever that is, that further compounds the nervousness that comes up into the pit of your stomach when you have to deal with a frantic situation that has a critically ill or injured child. So, first step, the tones have dropped. The call is out there. The facts are the facts that as soon as those tones alert, your heart rate goes up. It doesn't matter what the call is, just the sound of the tone is enough to raise your heart rate. Further add into that you will encounter an increase in your adrenaline when you start hearing critical situations involving kids. So have some idea of what your top injuries or illnesses are for kids. Open your protocols, go through them. No matter what your topic is for training, always account at least a few minutes to that session to talk about how we would treat a pediatric. If you're talking about spinal immobilization or splinting, great. But don't forget to include the fact that you're not just caring for adults. How would you splint that child? How would you do spinal immobilization for a child? All those types of things. Then, when the dispatch process is going on, you've gotten your call assignment, you know what's going on. Get in the cab, figure out where you're going, communicate with your crew, and come up with a list of a few things based upon the chief complaint that the dispatchers gave you that could be the cause. If you're paged to a 3-year-old with altered mentation, list out some things. Start that thought process. You're not going to tunnel in on them and get tunnel vision. You're going to avoid that. But at the same time, you're going to think, okay, altered mentation, seizure, hypoglycemia, infection, respiratory or some sort of ABC compromise. Start putting those things together so that you can come up with a list of at least 3 to 5 things that you can start ruling out that are the most critical, because try to divide the call up into what can make this child go into cardiac arrest before I get them into the ambulance. Those are the things I need to fix first. If I can get them to the ambulance, what are the things I need to fix during transport? What things do I need to assess for? All those things, and that can start developing a game plan. If you go into a pediatric call, or any call for that matter, without a good solid plan of who's doing what, it becomes very chaotic, especially if your crew members aren't used to working together on a regular basis. If you're lucky enough to have a partnership with a fellow crew member that you've worked together for several years, yeah, you can almost have a full conversation with a couple of looks across the cab. But the more infrequently you work with someone, the more you need to communicate. Okay, here's what I'm thinking. When we get on scene, we need to assess for these things. I'm going to do the following, and I want you to do these things. That way you guys have a list of what needs to be done in those first 5 minutes of patient contact, so that you're not stepping over each other. You don't have 2 or 3 people trying to ask the family or the patient the same questions, and they don't know who to look at, who to talk to. And so that you can have a coordinated plan to try to gain control of a frantic, scary situation. Because what has happened is something that has occurred, whether it's medical or trauma, that has probably scared the child, which is in turn scared the parents, which becomes a vicious circle. The more they're scared, the more they're upset, the more the child becomes scared, the more the child becomes upset. So that vicious circle just continues until you can step in and start getting things under control. You don't have to memorize the world. When I first started as a paramedic many years ago, one of the courses was to take PALS, and you had to have everything memorized front, back, and be able to regurgitate it on a minute's notice. That's not safe. Memories are faulty. Protocols change. Find ways to be prepared. You have to do math when it comes to pediatric doses sometimes. Know how to estimate a weight for a child while you're still on the road, getting to the call. If you're paged to that 1-year-old, typically they are about 10 kilos. If you're going to a 1-year-old having a seizure, pull up your reference guide, whatever device you use, do the math. Have those doses as far as the milligrams or micrograms or whatever drug you're dealing with, as well as the fluid amounts that's going to require. That way you don't have to do medic math while a hysterical family and a critical child are laying there needing your assistance. You can have all that set, write it on your glove, write it on your notepad, write it on your tablet, whatever it is, have it set and ready. So the moment you open the door and walk into the house or up to the scene, you are set, ready, and willing to be able to take care of this child and start bringing order to the chaos that's going on. Word of caution, though, doesn't matter what device you're using, mistakes get made. There is plenty of room for debate over length-based versus weight-based thought process. What if the child is extra skinny? What if the child is obese? I'm not going to get into that debate tonight, but sometimes there are misprints. Sometimes there are different thought processes. Oftentimes, guides have the same drug listed for a variety of different conditions. Epinephrine, you have cardiac arrest dose, you have vasopressor dose, you may have anaphylactic dose. So if you glance at the wrong one, then you're liable to make a med error, whether it's underdosing or overdosing that child, a med error can still occur. The other problem with commercial devices, no matter what device it is, the challenge you run into is how often do they match what your medical director has authorized you to do? So we want to keep it simple, but at the same time, we have to realize there are flaws in every system. It's just an inherent part of life that you have to contend with, and sometimes the system is not set up in the best or safest method. We're all probably experiencing medication shortages. Over the years, we've had issues with getting certain meds. So how can we design the system to be more safe? At one point in time, we had 4 different medications that all came in little vials with blue tops. One to speed up your heart, one to slow down your heart, one to make you sleepy, one to take away the nausea, and then one that made you sleepy with a little Benadryl. What do you say we don't put those 4 vials right next to each other in our med bag system? Let's find a way to do it safe, but keep it simple. So we went through our protocols that our medical director has developed and has authorized us based upon the equipment we carry, the medications we carry, and the situations they can be used in, and develop this reference guide that is in paper copy in our pediatric kits. It is in electronic copy on our unit tablets in the ambulance, as well as available to any of our staff and our first responders through our protocol app. This way, if they know that they're going to a newborn, they know the airway size that's most likely going to be needed, they know respirations, they know everything that they need to know about equipment and medications that we carry for this child. If there's a situation where that medication is contraindicated, it's listed. If it's allowed to be given, then the milliliters and milligrams are listed so that the math is done based upon ideal body weight. And then they are ready to be able to pull this up and administer the medication or apply the equipment as needed so that they're not in a frantic situation trying to figure out which size eye gel they need, how much medication should they give in this critical situation. So it's all preset for them. They can look at this up on the way to the call, and it's already pre-done. They just verify. The big thing that they really have to verify at this point is to making sure that the concentration listed on the reference guide matches the concentration that appears on the ambulance. Because as I said, medication shortages mean we don't always get what we typically order. So sometimes we are at the mercy of the vendor, and what we get is what we get. The next part, practice, practice, practice. I won't play the video because it's a fairly lengthy video, but it is something that you have to do from start to finish, whether you're a first response agency that doesn't transport, whether you're the transporting agency, whether you're the emergency department of a critical access hospital or urban trauma system. You have to do things with each other. You have to be able to demonstrate situations, give everybody's perspective. In this particular situation, They came in, they did a mock pediatric arrest in the emergency department from everything that they would do in that cardiac arrest of that kid on scene to the point of loading the mock patient onto the stretcher and taking him over to the emergency bed and rehearsing and walking through the transfer of care to that patient. We do that on a frequent basis with Peds, we do it with stroke, we do it with trauma, we do it with STEMI with our local hospitals, as well as a variety of other types of situations. So you have to be able to do these things, take the time to do them so that the hospital can understand your perspective, you can understand their perspective, because it really takes an entire team and a village to sometimes save these critically ill or injured individuals. So when they find out you're bringing in a child in cardiac arrest or active seizure, their adrenaline's going to be up as well. Most small hospitals and even some of the larger hospitals don't deal with life-threatening emergencies in pediatrics on a regular basis. Come in controlled. If you've taken the time to rehearse with these individuals, they know what's to expect from you, you know what to expect from them, and it makes that transition of care much more smooth. It is a lot safer for the patient, and it instills a level of confidence in the family that, hey, this is a professional project here. They know what they're doing. They're going to take good care of my child. That's another level of reassurance that you can apply to the situation to help get things under control. I won't go into a lot of detail about the pediatric assessment triangle. Many of you have probably heard a lot about it. We may hear about it in our next presentation. But the overall thought is that you can do a very good initial rough assessment of how sick or injured your child is, how well they're compensating within those first few seconds. Like I said earlier, what are the things that I need to fix between the scene and getting this child into an ambulance? Those are the things I have to identify and learn to trust my gut. We've probably all been in a situation where you haven't had that chance to relax and take a deep breath before you even open the cab door and get out. This is one of the few things that I do really stress to our local first responder groups is please, 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 when you have a sick or injured child, don't bring them running to the ambulance. Let me come to them. You're scaring the kid. You may even be harming the kid. And you're certainly probably going to upset the family. Not to mention, sometimes you bring me a child that I cannot do anything with because they're deceased. And so getting everybody's adrenaline up, getting hope raised for a family when you know that the resuscitation will not occur is an injustice to them. It gives them that false sense of hope, only for you to have to turn to them and say, I'm sorry, your child is dead, and bring that crushing reality to them. So this is one of the few things I stress. Please don't run to the ambulance with a kid. Let me come to them, get things under control. Don't do things that will raise my adrenaline. Don't do things that will raise my partner's adrenaline. Let us do our job in a calm, cool, safe, collected manner. So know what your situation is. Measure, measure, measure. Know how well you're doing. Analyze what's working. Analyze what's not working as you can try to make improvements in pre-hospital care for these kids. And I think I'm getting a little bit close to my time, so I will kind of jump through a few of these things. But go for the low-hanging fruit. but you got to figure out what's not working in your system and what is working so you don't inadvertently break something that was going well while ignoring something that may be in dire need of some attention. So take your time with these kids. We've evolved pre-hospital care on the adult side to work pit crew CPR in a lot of organizations. You set up the resuscitation the same in the adults as often as you can. Airway has their triangle, compressors have their area, monitor, IV access, they all have their appropriate assignments. We really need to adopt that thought process with kids. Whether it's cardiac arrest, whether it's an active seizure, take a few minutes on scene to get the child stabilized to the best of your ability. Assure airway, assure breathing, compressions as needed, get vascular access, and treat them appropriately with whatever pharmacology is indicated for that situation. Then think about transportation and do it safely. Make sure they're restrained. Families riding with you, make sure they are restrained. We've all probably got a horror story, and it may be very old, it may be very fresh, about someone running a child to you in cardiac arrest. You jump in the back of the ambulance, you start resuscitation, somebody whose adrenaline is already pumping hops behind the wheel of the ambulance. You're hanging on with one hand on the grab bar while trying to do compressions, while trying to apply the monitor, while somebody's trying to get access, while somebody's trying to control an airway. And really, how often does anything really get done for that kid when you're bouncing through the city streets and out on the highways because of the ride you're getting, because the adrenaline that's pumping for everyone? Oftentimes you're not providing good care, if any care at all, in that type of situation. Take a good 5 minutes to get things under control, get an airway established if needed, assure breathing is working, assess circulatory function, get access if you need to, medicate as needed, and then you can start the process to safely transport this child to the hospital. Unfortunately, we see ambulances in crashes on a regular basis in the news. We don't want you as providers to become one of those statistics. It is up to you to be able to have a safe situation, a safe scene, and a safe transportation to the receiving hospital. Your life depends upon it. This child's life depends upon it. And everyone out there in the public depends upon you being able to safely navigate the trip to the hospital. A little side note, we don't use lights and sirens on a absolute requirement basis. We view them as a tool, much like your stethoscope, much like oxygen, much like your airway, much like an IV. When it's indicated, use it. When it's not, don't. So it's up to you to get some time to be safe with these kids, but learn to trust your instincts. If you walk in and that first 10 seconds of looking at that child and go, that's a sick child, trust that instinct. It is up to you to be able to start recognizing those things when you're jumping through your assessment triangle and just watching that child to know what's going on, get some idea of how stable they are, they aren't, and start developing a treatment plan that's going to start helping that child. Granted, the pictures I slide through in this presentation are a snapshot in time, but a lot of times you can get some sort of indication just in that quick few seconds of the child moving, not moving, paying attention, frantic, retractions, accessory breathing, modeling, all those things, external bleeding, deformities, whatever the situation is, lying motionless, you can start figuring out what's going on with this kid and be able to start developing a plan. So you're dispatched to a respiratory call. Start going through those few things that could be causing respiratory problems while you're on the way to the call. Asthma, airway obstruction, croup, epiglottitis, whatever the case is, start thinking along those lines. What treatments do I need to do for that child? What assessment pieces do I need to do for that child? And what does your gut reaction tell you when you walk in and see that scene? What's going on? You're assessing the entire thing. It's not just scene safety BSI. It is a matter of truly assessing the environment. You're looking at the patient. You're looking at their interactions with the responders. You're looking at their interactions with parents or other family members or bystanders. You're assessing everything. Your brain is taking in a lot of material every second before you even make patient contact. You've got to start processing that and looking for the red flags in the patient presentation, in the environment, in the interactions, so that you're better prepared to be able to adapt your treatment plan, because you may get in there and find something completely different than what you were expecting. And so you have to be ready to adapt on the fly and make those things happen. So you're looking at their appearance, their work of breathing. Are they struggling? You're looking at circulation to the skin. Trust that gut reaction. And then you can start having the discussion, making contact with the patient, figuring out what kind of rapport you're going to be able to develop, how you're going to do it with this kid, and approach them in what is an age-appropriate manner, talking with them, talking with the parents, and figuring out what's going on with this child. So, like I say, you can take in a lot of information in that first few seconds of just walking into the scene before you even introduce yourself and trying to develop a rapport with the family and with the patient. So take your time, but recognize those red flags out there that will think, hey, this is something I need to fix before we get in the ambulance. This is something that can wait, and start going down that process of, let's treat the life threats first, then let's get things stabilized, get things under control. So I think I'm coming up on time, so I will stop there for questions, and I hope we've been able to spur a little bit of debate and maybe a thought process to try to adapt some change for some of you. In some very progressive organizations, you may already be somewhere in the process of this. Other organizations are not as fortunate and not able or not ready to make that leap yet, based upon what administration or their medical director or the local hospital or the regulatory agencies allow them to do. But hopefully it can start the discussion process on how things can adapt and be made to be better for our patients. So with that, I will stop and open the floor, or let the moderator take back over. Vicki?
Thanks, Con. We do have one question, and it is, what about whooping cough? So, not sure what about whooping cough, but probably something that we could address is the growing prevalence of illnesses that previously we didn't know much about because we didn't see them, like whooping cough and measles, other things like that. What would you recommend about educating ourselves?
Yeah, I talked quite a bit about interaction with the hospital and responders as an entire teamwork. And I think probably two of the important organizations to bring into that loop at your local level is, one, your public health department, knowing what is prevalent in your area is very important. You know, we're seeing cases of measles pop up in Kansas, nowhere near the numbers that other states are seeing as of yet. But you know, having that discussion on a semi-regular basis with your health department is a good start, as well as the infection control department of your hospital. What are they seeing? That they are the experts in how to handle the appropriate personal protective equipment needs that you would need to have, as well as really honing in on disease specific conditions and signs and symptoms, and being able to know what best practice is in that locality based upon the hospital's capabilities, based upon the EMS agency's capabilities. So I think having those discussions on a regular basis are a good idea, especially as we see things like measles and whooping cough and those types of things coming in. Our particular area in 2026 is hosting a lot of people coming in for the World Cup soccer or football in the summer of 26. So we're trying to be ahead of the curve a little bit and learn about not only the cultural aspects of interacting with people coming from different countries, but also the disease processes that we may encounter, whether it's in a communicable disease or not, but how to best interact with them so that we can be respectful of their cultural backgrounds, as well as knowing some of the things that we need to be prepared for.
That's a good point. I think we've had speakers before who have stressed too just the importance of pictures. You know, there are certain signs of measles that kind of distinguish it from other things and other rashes and that kind of thing, and mouth lesions, that sort of thing. And also sounds. You know, if you can find videos of that where you can listen to breath sounds of different respiratory issues, that's really helpful in discerning one from another, I think. Would you agree?
I would, yeah. There's a plethora of information available out there from trusted resources that you can find online, and be able to have visual and audible education material so that it helps some of the stuff you just cannot simulate in a classroom setting. So that those are very helpful tools.
Agree.
I have a couple of things I could add about pertussis too. You're right, Vicki, we're seeing a resurgence due to vaccine hesitant and vaccine no thank you folks. But one of the main things for EMS to remember is that if you're picking up a symptomatic patient with respiratory symptoms, you should have your mask on. Pertussis is pretty contagious, and it is treated by it is a bacteria treated by antibiotics. So if you do get exposed, or you found out that you get exposed from your local health department or hospital, you probably need to get treated for that, and certainly make sure that your vaccines are up to date. The cough is distinguishable because they call it whooping cough, because they cough till they can't stop, and then they like whoop as they suck back in. And so that's how you can distinguish it from other types of pediatric coughs.
Very good. And on that note, thank you, Con, so very much for being with us. We appreciate your time very much.
Thank you. Have a good evening, everyone.
Thank you. And we'll transition to Becci. Becci Meredith has over 27 years of pediatric and neonatal nursing experience with background in NICU, PICU, ECMO, and transport. She currently is the Transport Outreach Coordinator for Children's Nebraska Hospital, where she provides education and support to hospitals and EMS agencies across the region. Many of you probably know her or have seen her speak or have benefited from her help in a tough situation. She is here to present Could Be You Case Review, Developing Your Spidey Sense. And I will tell you, Becci, if you could, we can see your slide and then also your next slide, like we can see the presenter view.
There we go. Try it again. Is that the same?
Perfect. It looks perfect.
Okay.
I'll turn it over to you, Becky.
All
Meredith.
right. Thank you. Thank you so much for that introduction, and thank you, Con, for setting this up for a great evening talking about pediatric EMS. For those of you guys that don't know me, I work in Omaha, but I live in a rural area, so I can sympathize with a lot of you who live in an under-resourced area. We play 8-man football, where my kids went to high school. A little bit about Children's Nebraska for some of you that don't know. We are a freestanding pediatric hospital. The transport team that I am the outreach coordinator for, we have some ambulances, a helicopter, and an airplane, and we serve a multi-state region, primarily Nebraska, Western Iowa, and then pockets of all the other places that touch us too. We do around 3,000 calls a year and bring patients back to our tertiary care center. So Con did a good job of talking about how we need to be careful not to, get triggered by some of the things that we see in here. That's really hard. I get asked to talk about hard topics all the time, and I do try to be a little bit funny and make them fun. But it's only because no one ever asks me to talk about anything that's funny. So as we're going through, I want you to be relaxed and have a good time and get some good takeaways. But I'm not trying to be flippant or anything like that when we're talking about pediatric patients. What I would really like you to take away from this is to not just be a monitor watcher, not just kind of get siloed into thinking what's going on with your patient or stick to your protocols like they're a cookbook. Just really look at everything, your vitals, your assessment, the history you're getting, and make some decisions from there. Let's see, there we go. So real cases that were picked up by my team or other teams and brought here to Children's Nebraska. Some of them are kind of outliers, and so that's why it's fun to talk about them, because they can really expand your mind a little bit as to what types of things that you might be seeing. So I did get some help from one of my sons. He's a big Spider-Man nerd. And so I have labeled some of our most common pediatric 911 calls as Spider-Man villains. So Mysterio is going to be respiratory distress. Green Goblin will be sepsis. Rhino will be abusive head trauma. Shocker will be anything cardiac related. Venom will be ingestions. And Electro will be seizures. Also, throughout the lecture, anything that you see from the assessments, vitals, or history that is in Spider-Man blue are things that should be making your senses tingle. Things that are just a little bit different, things that might guide you to what your cause of illness or injury would be and what might change your pre-hospital interventions. Like Con said, we don't all have to have everything memorized. I encourage you to use your resources, especially knowing what your pediatric norms are. That's a really common pitfall. There's a lot of times when people will say, I think they have SVT just because their heart rate's, in the 130s or 150s, but that might be a normal heart rate for that patient for their age. So I always encourage EMS agencies to, on the way out to a call, have someone say out loud, our heart rate should be, our blood pressure should be, our respiratory rate should be, and then everybody knows when the first set of vitals is called out what you should be nervous about. For if we have anyone on here who works in an emergency department, I likewise encourage you guys to do the same thing, maybe even go so far as to write the vitals on the whiteboard in your ED. That way, anyone who walks by the room knows what they should be and what the patients are currently and what they look like. That can really help you catch some of those kiddos, like Vicki said in the beginning. They compensate really well until they just don't anymore. And sometimes it's those subtle symptoms that we miss. Weights also really important. Be careful about stated weights. Always use, I say use a Breslow tape. They don't pay me. That just happens to be what our hospital uses. Any type of weight-based resource that you use is appropriate, whether it's one provided by your agency or Hand-Tevi or Breslow or whatever it is, but just do use some sort of weight-based resource to help you make decisions about equipment and about medication dosing if that's appropriate for you. And also something we encourage people to do is to encode with a Breslow weight for any critically ill or injured child to the hospital you're going to. Because many of you will be going to a place where they don't take care of children a lot either. And so they also get really nervous and it takes them a minute to find their things and remember their protocols. And so just giving them that heads up can be really beneficial. Some assessment tips to kind of help you as we get started. Always remember your ABCs and your PATs. Con did a good job of talking about your pediatric assessment triangle, that from the door, sick, not sick, helping you decide if you need to intervene or if you have a little time to schmooze everybody first, which can be very beneficial because schmoozing is a powerful respiratory intervention. When your little kids are nervous, they have a harder time breathing. And if that's why you got called first anyway, that's only going to make it worse. Also, always, always, always pay attention to the heart rate. Watch it often, know what your norms are. Adults have lots of ways to increase their cardiac output, but small children and infants only have one, and it's to make it beat faster. So anytime you have a child with a high normal or higher heart rate, and it's higher every time you check, that's a child that you really need to be reassessing and be going back to the drawing board, thinking about what might be causing this and what can I do to intervene. Another thing that I would love to see you all implement in your practice is when you're doing that initial head to toe assessment. I have my baby here, and so hopefully you guys can all see him. He says hi to everyone. When you first walk in a room and you're assessing your less than 12-month-old patient, I would love it if you would simultaneously feel the brachial pulse and rub that fontanelle at the same time as you're looking at them. Because when you're looking at them, you're going to see their color, their level of alertness, if they're breathing too fast or slow. And then when you're feeling their fontanelle and their brachial pulse, you're getting a good quality of their pulses for your cardiovascular exam. And then by feeling that fontanelle, you are assessing for a brain illness or a brain injury. Oftentimes we miss abusive head trauma in children. So if we get in the habit of just always feeling that fontanelle, anybody less than 12 months old, that'll help remember us that could be on our list of what could be wrong with them. And then it might prompt us to check pupils in your child, which maybe you wouldn't always do depending on what you got called for. And then exposure is something I really want to hit on. Little kids can't or won't tell you what's going on. And so we have to be good detectives. We need to look underneath their clothes, look for any signs of illness or injury, and then cover them back up so that they can stay nice and warm. Okay, so be looking for the things in blue for your spidey senses and remember those few assessment tips as we're going through. The first one is Darling Darla. She's an 8-day-old female in respiratory distress. None of my pictures are of these real children. They're just cute ones I got off the internet. So your history you have ahead of time. But they haven't found anything necessarily that is a red flag to them. So your awesome EMS agency, when you get there, you notice that grandma says she seems to have more trouble after she eats. That should make your senses tingle a little, only after she's eating. She's breathing labored, shallow at 30 times a minute, which is okay for a newborn, and her heart rate is 148, which is okay for a newborn. She has decreased lung sounds. She's cool, pale, cyanotic around the mouth. That's never good, right? Her stats are 88, despite you putting her on 15 liters non-rebreather. You cannot get a sat on her foot no matter what you do, but when you put it on her right arm, you get a sat of 88. You give albuterol twice on the way to the hospital, but it does nothing, and her sats still do not increase. Grandma's a NICU nurse and keeps telling you she's not acting like herself. And you placed her in a PD mate. Good job. Con mentioned that too. Safe securement is really, really important. A+ for some sort of a ambulance crash tested pediatric securement device. B or high C for using a car seat, especially if it's been in an accident. We don't want to reuse those. I always tell people to use the best option that you have in that moment, and that might look different on every call, especially if you have more than one patient. But gold standard is always a crash tested pediatric securement device for an ambulance. So in the ED, they look toxic and gray on arrival. I'm going to say poopy since I'm being recorded. There's other words I might like to use if you guys know me in person. Her temp is low. So babies with low temps and high temps, that's a huge spidey sense tingle. Her initial venous blood gas is 6.9. It should be 7.35 to 4.5. So 6.9 is very, very concerning. And her carbon dioxide level is 93. It should be 35 to 45. So she is not breathing effectively. Her chest x-ray is normal, no murmur noted. She's placed on heated high flow, but she still has disorganized breathing. So when you're assessing your patient's breathing, it's not just what is the rate and is their chest moving? Is it a normal inhale, exhale? Do you hear the same sounds on the left and the right side? Are they belly breathing? You know, is it regular or is it irregular? Do you know apnea? She was given 10 cc's of normal saline. And your normal pediatric fluid resuscitation should be 20 cc's per kilo. We'll talk about this 10 cc's in a little bit. She did need emergently intubated, though they had some trouble getting her tube in. She vomited during the attempt. She had some sustained hypoxia and a code event where she got some epinephrine and bicarb. They did start prostaglandins in the ED, which we'll talk about. Because she had a normal brachial pulse, that's where we check it on the little guys, and a weak femoral pulse. So they asked the cardiac ICU to come down and do an echo just to see what they would find. Okay, so you have all that information. You have the blue things that are making your senses tingle. Here's your villains again. If I could see all of your faces, I'd have you raise your hands for like, is it Mysterio? Is it Green Goblin? And at this point, it could be several of them, right? Because we don't have all the answers. That's the point of your spidey senses. I know that you guys are not diagnosticians and doing this out in the field, unless some of you might be providers out there, I'm not sure. But in general, our EMS people, you have a list of things that you think is wrong and that you make decisions about. So hopefully on your list, you had respiratory distress as a possibility, sepsis as a possibility, abusive head trauma, always fill that fontanelle, or undiagnosed congenital heart disease. Maybe some of you had that and some of you didn't. I like to say that every time you pick up a patient that has trouble breathing, you should think, might it be these 4 things? Always. You should always be thinking about them and wondering if it's it. So the answer is, shocker, she had a undiagnosed congenital heart defect. She had a severe coarctation of the aorta. I don't know if you guys can see my arrow from my mouse, but if you look at where the blood comes out of the left ventricle and up through the big giant hose aorta and then gets super skinny right in here, that is where the coarctation is. And so what happens there is she does not have adequate blood flow to the rest of her body, but she will, particularly on the right upper extremity, and that's why we were getting a sat there, but not in her feet. That's why there was a difference between her pulses, uppers and lowers. So things that might make you think that your patient has an undiagnosed cardiac defect. Again, you should suspect it with any newborn patient that's having respiratory distress, but no signs of infection. Remember, she wasn't snotty, she wasn't wheezy, the albuterol didn't help. Oftentimes, initially, these are misdiagnosed with a respiratory infection, just like our little lady here was. Things that you might clue into in your history when you're talking to family. These babies, they're crabby. They don't feel good. They have skinny little arms and legs. They feel worse after they eat. They don't eat well. They don't gain weight well. They get real sweaty. All of these things, remember, that grandma was trying to say in the beginning. So what should you do in the pre-hospital setting if you suspect this? Largely supportive care, which is what all of EMS is, right? We want to give oxygen, even though it didn't necessarily work. What they were doing without realizing was called a hyperoxia test. And so we'll do that sometimes with our congenital heart babies. You put them on 100% oxygen for 15, 20 minutes, and then we'll check an arterial blood gas and see if the PO2 is higher or not. And if it's not, it might mean that they have a congenital heart disease. End tidal monitoring could have been really smart in this case if you have that capability for your agency, because it should be 35 to 45, and in the ED, hers was in the 90s. So that might have clued this agency into that she was not breathing effectively. Remember, in the ED, they described disorganized breathing. They did administer prostaglandins. So what prostaglandins does, when babies are in utero, they have something called a PDA, patent ductus arteriosus, and that helps connect the right and the left side of the heart. And when baby's born and starts breathing oxygen, that starts to close off. And so when that closes off, if they have certain heart defects, that's when they'll start to decompensate and have cardiogenic shock like this little one. So it's smart to check your upper and lower pulses and compare them. Sometimes what we will do is check a blood pressure in all 4 of the extremities. And if the mean, the number in blood pressure parentheses, is off by 10 between the upper and the lower, that could mean they have a cardiac defect. And then we want to prevent any worsening symptoms of congestive heart failure. So that's why it was really smart that they gave 10 cc's per kilo instead of 20. If you suspect some sort of heart failure, it's always smart to start out with 5 or 10 cc's per kilo and then work your way up from there. So what happened to this little one? She was intubated in the ED on the ventilator. She was placed on a prostaglandins drip. She was started on fentanyl and Precedex drips to keep her sleepy because no little ones like to be open with the tube in their mouth. She did have a normal brain MRI. They wanted to check that because she had had some hypoxia pre-hospital and in the ED. She was also post-arrest. So she went to the cardiac OR the following day, where basically all those words mean that just that narrow part of the aorta, they did a cut here and here and then put the 2 better pieces together. She was extubated on post-op day 2, and then she went to the med-surg floor. She had to, get better at eating because she was a terrible eater. She just didn't feel good enough to eat before, and then she was able to go home. She was enrolled in Project Austin. That's a whole separate talk, but for those of you that are not familiar, please Google it. It is a program for our medically complex children that was started here at Children's Nebraska, and it bridges the gap between hospital and EMS and families. They are starting a national collaborative now as well, so for those of you in other states or that work with other pediatric facilities, if you're interested, just Google around on that. Okay, our next patient, Tommy Toddler, he's a 2-year-old, and you get called because he is poorly responsive. No significant medical history on him that you're given. Your awesome EMS agency monitors him on the way to the hospital. For his AVPU, you note pain only. This is, again, part of that pediatric assessment triangle. You're trying to elicit some sort of a response. If he's only responding to pain, that should be tingling. His GCS is 7. A lot of people like to say GCS less than 8 intubate. I personally think GCS less than 8 consider intubate. There are some children that are able to protect their airway and they don't need to be intubated, so that's provider discretion. If you are able to have some discretion like that, you can prevent perhaps a code event during an intubation, you can prevent a ventilator-related pneumonia, and in times of high census all around our country, you can prevent taking up an ICU bed for a child that doesn't need it. He also had bradycardia and hypotension. So the fact that he has hypotension means that his bradycardia was symptomatic. He probably had delayed cap refill. His blood pressure was lower. He might have looked a little mottled. And then they did do a 12 lead and noted some inverted T waves. In the ED, he got a couple doses of normal saline. He got some atropine for his bradycardia, and he had a delayed sequence intubation. And they had a pretty tough time getting him intubated before the transport team got there. Okay, so be thinking back to your villains again. Could this guy have respiratory distress, sepsis, head trauma, some cardiac etiology, ingestion, seizure? I wish I could see all your hands and faces. So he could have abusive head trauma, right? Low GCS, alert only to pain. He could have respiratory distress, though we didn't, necessarily note anything about snot or lung sounds. He could have an ingestion. Little guys get into things on accident, big guys on purpose. He could also have sepsis. When you're septic and you don't get enough oxygen to your cells, then your brain starts to make you more sleepy and less alert. All right, our villain is venom. This guy ingested clonidine. We always want to ask our families about what substances in the home the patient has access to. And for my ED folks, we always want to tox screen any patient with a GCS less than 15. That's what we do here at Children's Nebraska, and you would be surprised what we see. There was one little one they thought maybe had some sort of a neurological emergency. She had a normal head CT. Her tox screen came back with a blood alcohol of 236. She was just super duper drunk. So you just need to always double check and see if that could be what could be wrong with your patient. Consult poison control all the time. We don't all know everything about everything that a child could ingest, so that's why they're there. 1-800-222-1222. I had it memorized because I'm a boy mom. They're all adults now, but I did call it more than once. So what does a clonidine ingestion look like? It's a very common drug used in adults for hypertension, but it's also commonly used in children with ADHD. And unfortunately, it's a frequent cause of suicide attempt in those children age 6 to 12. So we do encourage families to keep those medications locked up. And if your grandmas or grandpas, please put your pills up too. I joke a little bit that grandma and grandpa's house is a pretty dangerous place because little guys get into things all the time. The problem with a clonidine ingestion in children is that it causes very severe central nervous system depression and bradycardia. What a lot of people don't know is that it's responsive to Narcan. I believe it may be the only medication aside from a narcotic that would respond to Narcan. So what happened to this guy? Of course, we called poison control because they're the experts. He wound up intubated and sedated for 28 hours. He was briefly and initially on a Narcan drip and an epinephrine drip to counteract the effects of the medication. He ended up getting a few doses of steroids because of his history of difficult intubation. And he remained altered for 48 hours because of the long half-life of clonidine. He did go home well on day 3. So what should you do in the pre-hospital setting? ABCs, PATs. Use Narcan on patients that you suspect an ingestion with a GCS less than 15. You should consider it. A single dose of pre-hospital Narcan will not hurt anybody. I promise you it will not. And if it makes your patient better, good for you. And if it doesn't, didn't hurt anybody. Consider using modeling, delayed cap refill, hypotension. Use end tidal monitoring for any of your patients with a GCS less than 15. It can be a very, very valuable tool and help you decide quickly if your patient needs more intervention or not. All right, next one, little Lila. 4-year-old, you get toned out for seizures. She's a pretty healthy little one. She had a seizure at home. Your awesome EMS arrives and you're told everybody in the house has influenza. When you are assessing her, you notice clenching of her upper right extremity and upward eye, whoops, left, it says left, right, upward eye gaze. Any type of movement or eye gaze or something like that that you can't interrupt might be a seizure. So when they're doing that eye gaze like that, snap your fingers by their little face and see if they jerk. If they don't, maybe it's a seizure. If they're moving their arm or they're holding their arm up really tight, see if you can interrupt it. If you can't, it might be a seizure. If they're a baby, a lot of times little babies that will do like a lip smacking kind of thing or tongue thrusting. So if you're trying to see if that's possibly a seizure, put a gloved finger in their mouth and see if they latch on and suck on it. If they suck on it, it's probably not a seizure. If their tongue just keeps rhythmically hitting your finger, then it might be. So this agency gave some nasal Versed. They monitored the patient, and the GCS was 11. So we're going to do a tox screen and all those things. In the ED, she continued to seize, so that's a problem, right? We want to try to stop our seizures once they get going. Her temperature was high, so again, low temp and high temp are concerning. She got a dose of antibiotics. She received more Versed and Ativan. They checked her glucose and noted it was low, so she got a D10 bolus. We do 5 cc's per kilo with my program. She got a Keppra load dose because the seizures were just not stopping. They did give her a dose of Solucortef because there was a questionable history of adrenal insufficiency. And then she had a delayed sequence intubation for status epilepticus. So what prompted all of these seizures? Let's go back to our villains again. Here they are on the screen. So again, each of these cases could be any of these, not any, but some of these different villains, right?
So
I don't expect you to know everything. What?
Our beautiful and talented Kjelsey has created a poll so people can actually vote for which character
Oh, I
is
love it.
representative. So
I tried to do that earlier and I
vote
couldn't
away.
do it.
She's
Great.
awesome.
So we're going to
everybody,
see
go ahead
on
and
these.
vote.
Yeah, thank you. All right, you'll have to tell me what people voted because I can't see. Oh, I see. Looks like a lot of people think sepsis. Yeah, that's for sure. Let's see what I have next here. There we go. So here is your differential. Seizure, right? Because that's pretty easy. Abusive head trauma, though, that can make patients seize. Some ingestions can make patients seize. When you're thinking about your seizures, they can be simple febrile, which means their fever just goes too high too fast. And it's usually kind of a one and done with a short post-ictal phase. Complex febrile seizure means they've had more than one in 24 hours. It lasted a really long time, or they had a really long post-ictal phase. And then epilepsy means that we know they have a known epileptic disorder, or maybe they're diagnosed with a new one. This little one actually had something called influenza encephalitis with edema from status epilepticus, so electro. It's a neurological condition that can occur rarely in some children following an influenza infection. It is associated with severe seizure. It is treated supportively, but unfortunately, it can be really swiftly severe and really a dangerous thing to have. It is prevented with vaccination. So management in the pre-hospital setting, we want to treat seizures per protocol. Nasal Versed is awesome because you don't have to start an IV. You don't have to access their rectum. You can just draw it up and give it. You want to manage their airway as indicated. We want to use our end tidal again to help us decide if they're breathing effectively. We want to use neuroprotective measures in this little one. We can't do anything about the brain injury that happened before we got there, but we can help prevent a secondary brain injury. So what we want to do is have the patient's head of bed up like 30 to 45 degrees. We want their head midline because babies and kids have smaller vessels in their necks. So if their head is turned to the side, it's going to squish it off maybe. We want to keep their end tidal 35 to 45. We want to keep their oxygen 94 to 99, kind of like Goldilocks. Not enough oxygen is bad for the brain, and too much oxygen is bad for the brain also. And we want to have a normal blood pressure. This part is really, really important. No, no hypotension allowed, no permissive hypotension. And then we want to decrease stimulation. So turn down the lights or put a blanket over their eyes. Turn down your radios or maybe turn them all off but one. Try to talk quietly. Think about things that you would like if you had a really, really bad headache. And almost all of these things are BLS interventions, but they can go a long way towards improving our outcomes. So what happened with this lady? She had really unstable blood pressure. She required vasopressin, norepinephrine, and epinephrine drips. She was intubated at the outside hospital. She was taken emergently to head CT for non-reactive pupils, and there was lots of brain swelling. She got several doses of 3% saline to try to decompress her brain. The neurosurgery team placed a bolt in the ICU room because they were concerned her brain was going to swell enough that she would herniate. Her initial ICP pressure was 47, and anything above 20 we get pretty worried about. She had an emergent bifrontal craniectomy where they removed parts of the skull bones to try to give her brain room to expand so that it can heal. Ultimately, despite all of that, she just got so sick so fast, and she did pass away. Of note, the children, at least at Children's Nebraska this last season, that passed away from influenza, and granted this is a multi-state region, but none of them had received their vaccination. So kind of like the pertussis talk to your trusted providers and things like that to help you make choices about what you want to do for your children. But vaccines are really important. All right, Trisha Teen, 16-year-old female, you get dispatched for an allergic reaction. You're sent to a clinic for this one, and you're told that she has a history of peanut allergy. All right, you're awesome EMS. You note that she complains that her throat is scratchy. That should make your spidey senses tingle. So adults, and she's 16, so she can tell you more, but when I'm talking about like toddlers, for example, sometimes we admit them because they aren't as good at telling us my tongue feels big, my throat feels scratchy. So a scratchy throat should make your senses tingle. Mom gave her Benadryl before she took her to the clinic. In the clinic, she vomited. Vomiting in an allergic patient should always make your senses tingle and make you be worried. She got epinephrine and Zofran. En route, your awesome EMS monitored her and you gave more epi and more Benadryl. In the ED, she appeared flushed. So she's gotten all of these things and she's still having some skin symptoms. She got a liter of saline. She got started on H2 blocker. Decreased breath sounds. So remember, you should hear something. You should hear wheezes. You should hear clear. When they're starting to be very decreased like that, maybe it means they're not moving much air at all. So she got oxygen, Duoneb, steroids, saline, and more epi. By now she's up to her third epi. So she was admitted to the PICU for refractory anaphylaxis. Okay, so this one's a little bit easier. Here's your villains again, so we can put the poll up because there could be other things that could be wrong too. And if you're wondering what does anaphylaxis, we can call anaphylaxis shocker if you think, right? Because it's a form of shock. All right, going to go on to my differential list here. So could be an anaphylactic reaction. I see, yep, most of you guys are kind of getting that going on. Respiratory distress. Yeah, she is having respiratory distress. All good. It could just be a plain allergic reaction, right? People have allergic reactions all the time, but those are not anaphylactic ones. Or she could be having an asthma exacerbation as well. So she actually had anaphylaxis, and I don't have an anaphylaxis villain, but I don't disagree with those of you that would call it a respiratory distress villain too. So The symptoms of anaphylaxis, this is really important to talk about because so many of us focus on the more obvious ones that we're taught about, the hives, the swelling, the trouble breathing, because that accounts for the majority of symptoms. But you'll notice GI is 45%. And in children with food allergies, up to half of them experience GI symptoms as a sign of their anaphylaxis. So when should you diagnose anaphylaxis? If they have 2 or more of any of the following that occur within minutes to hours after an exposure. So they've got skin symptoms, they've got some sort of respiratory symptoms, they have reduced blood pressure or syncope. And syncope, I'll tell you, if they complain of being dizzy before you get there, you should consider low blood pressure or syncope in those patients, right? Because we walk in the room with all our stuff and our big loud trucks outside. And so maybe we get kind of a false bump in that blood pressure there. And then persistent GI symptoms, abdominal pain, nausea, vomiting, cramps. Remember, this gal, she was wheezing in the ED, but not initially in the clinic. She complained of an itchy throat and she vomited. So there's 2 right there. And they were already doing the right things by giving her the epi. I just wanted you guys to know some of these nuances so that when you're out in the field, as EMS providers, sometimes we're hesitant to give the epi. So I don't want you to be hesitant to give epi. Like Narcan, a single dose of pre-hospital epi in a child is not going to hurt anybody. So what should you do? Remove whatever is making them be anaphylactic. Give IM epi. Like I said, there is no reason why it would be unsafe for a child in a pre-hospital setting. You can also, if they're hypotensive, put them supine and raise their lower extremities a little bit. Oxygen is good for everybody. I put Benadryl ? Because Benadryl is nice, but it is not what anaphylaxis needs. Anaphylaxis needs early epi. In fact, the sooner you give epi, the better it works. The majority of patients who die from anaphylaxis did not give epi within 20 minutes. So think about your referral area. How long does it take for you to reach that patient and decide to give your dose? And there is a physician in Western Nebraska. His name is Dr. Smith. I don't know if anyone out there is listening, but he likes to tell people, your patient is so glad you gave them Benadryl so they won't be itchy when they die. That's kind of a very dramatic way to say, give your epi first. All right, so what happened with this lady? She continued to have hives and flushing. She was put on oxygen. She actually was on an epi drip in the ICU for a while, and then she got scheduled IV Benadryl and steroids. The next day, she was able to come off of that stuff, start weaning down to some albuterol every 4 hours and some oral antihistamines and steroids, and then was able to go home. Anaphylaxis is an important one to talk about. Just this week, I've read 3 charts of kids that needed more than 1 dose of epi, which statistically is not very likely. I don't know what happened here in Nebraska this week. All right, Rashy Randy, you get called for a 2-year-old. This is going to be a hospital-to-hospital transfer for y'all. Cellulitis. Background information, he's healthy. They think he has cellulitis from a bug bite. Limping noted on the right leg. This part should make your spidey sense tingle because little kids are tough. We'll have kids that are, end stage cancer and they're in the toy room playing. So if you have a child that won't bear weight or won't move an arm, you should be doing some investigation. There's something else going on. So in the ED, they have a high fever. We've talked a couple of times about this. Low temp, high temp, concerning. They're tachycardic, heart rate 220 to 225, which is super duper high for this age group. We do sometimes see heart rates of 220 to 250 in infants with SVT, but this child is older, so no matter how you slice it, this is high. They received a normal saline bolus and they got labs and antibiotics. Okay, so get ready to do our poll again. What is wrong with this guy? Put my villains back up. All right. So on your list, yeah, I see a lot of sepsis. Yeah, you can't necessarily rule out abusive head trauma. Ingestion's on there. Excellent. So what this patient really had was septic shock from MRSA. So MRSA can be community or hospital acquired, and kind of the hallmarks are red, swollen, painful, hot to touch, and a big old fever. So I've got a couple of pictures here, and you can see why people might think, oh, it's just an infected cellulitis. But with all of his other spidey sense tingling things, that would be super concerning. So we got our green goblin here, sepsis. So when you're thinking about sepsis and you're trying to decide might it be or not, time is a useful mnemonic to use. Is their temperature too high or low? That's about the fifth time I've said that tonight. Are there signs of infection in this guy? Yes, there was. Mental decline. Remember, we talked a little earlier when for some reason you're not getting enough oxygen to your brain cells, that's when that GCS starts to go down. And there are lots of things that can cause that. So mental decline, and then extremely ill. You know, if you have a little bit of cellulitis or you have a bug bite that's a little infected, you aren't extremely ill like this kid was. So management, I talked at the beginning, pay attention to your heart rates. This one was super obvious, but sometimes it's just at that high end of normal or just above. So always, always, always pay attention to your heart rates in your kids. You want to give oxygen. Shock is not enough oxygen to your tissues, so these people need oxygen. Fluid resuscitation, if you can, 20 cc's per kilo over 5 to 10 minutes. If you mess, you must reassess. So bolus, assess, bolus, assess. They might need up to 60 to 80 cc's per kilo in the first hour. We start our inotropic vasoactive meds at about the third bolus, but of course, follow your protocols. People with suspected sepsis, children with suspected sepsis need antibiotics. Every hour that goes by that they do not get appropriate fluid resuscitation and broad spectrum antibiotics increases the risk of death by 8%. So you think about our large rural referral areas that we have here in this HECC collaborative, an hour goes by pretty quick because the clock starts when the family calls 911 or when they show up to the ED. And I know that EMS cannot give broad spectrum antibiotics. If I ruled the world, I would let you. I would have you all do a sepsis screening tool, ask about allergies to medications, and then give a weight-based dose of a broad spectrum antibiotic. But because you cannot do that, or maybe you can in the other states, so I apologize if I don't know that. But if you cannot do that, what I want you to do when you drop off your patient or when you're encoding is say, I am concerned about sepsis. Because hospitals should have at least an adult, if not a pediatric and adult sepsis screening tool. And so sometimes just by you saying, hey, what about, will prompt them to start that process sooner because time is brain and time is healing. So what happened with this one? PICU hospital course, he was intubated and sedated. He was on norepinephrine, milrinone, and dobutamine, very sick guy. We put him on hydrocortisone. We oftentimes use that in septic patients with very labile and non-responsive to treatment hypotension. He was on multiple antibiotics. He was placed on venous arterial ECMO, which is a machine that's in the patient's room that can do the work of the heart, the lungs, and sometimes the kidneys. The very, very sick kids on this. He had several cardiac arrests. He had a right leg fasciotomy because of compartment syndrome around where that MRSA wound was. And ultimately, he had a stroke related to his ECMO and passed away. When patients are on ECMO, it's a delicate balance between keeping their blood anticoagulated for the machine and then combating the clottiness of their disease process. And sepsis can be a clotty thing sometimes. So an unfortunate outcome with this young man. All right, little boy blue. He's a 6-year-old male with cyanotic skin. Parents checked on Little and found him to be blue all over, so they scooped him up and rushed him to the ED, where they monitored him, they put him on oxygen, and they just called for specialty transport right away. So this one, if I could see the chat, I'd have you type in the chat what you think it might be, or you can pick your polar villain here. See what we think it could be. It's blue skin from New Sheets. See, I have to put a funny one in here because some of these are not funny. Yeah, it could be any of those things. You're right. Yeah, most of you are like, probably not seizure, probably not sepsis. So, it's important to be concerning. Why is he blue? Is he having trouble breathing? Are these other things going on? And so, the team ran in the room and they wiped off his hand to place an IV and all the blue came off and they went, oh, I guess he's okay. He just had brand new sheets and he got all sweaty in them and rolled all around. And so this just goes to show you that it's not just the number, it's not just a single piece of assessment, it's the whole picture, the history, all of that all together. So kind of going back to the beginning, remember your ABCDEs and your PATs. We want to do a thorough, systematic, head-to-toe assessment every single time. We want to always, always pay attention to the heart rate in our pediatric patients and be concerned anytime it is too high or going up every time you check it. For those kiddos less than 12 months old, please, after tonight, always check your fontanelle and your brachial pulse. Make it a part of your walk in the room, get going assessment, because that will help us catch some of these brain illnesses and particularly injuries sooner. And then exposure. Do always look under their clothes and under their diaper for other signs of illness and injury. Remember your spidey villains and the things that should make your senses tingle. Like I said, I know you're not diagnosticians, but I think that you've seen with these 6 cases that when you're getting toned out and when you're gathering your information, there could be several things that could be wrong with your patients. And we want to be able to be nimble and not get stuck on a number or stuck on a story. And lastly, take care of yourselves and each other. I do have to give credit. This is my youngest son, Seth. He's 21 now. The picture on the left, he likes them now. He hated small children, including his cousins and his siblings. So that's the one on the left. And then on the right, he's a bit more better adjusted college student there, home for Christmas. There is my work number and my email. If you have any questions about tonight's presentation or you want to talk to me anything else pediatrics, please do so. And then the HECC folks know how to reach me, especially Nebraska and Iowa's, because I talk to them quite a little bit. I really appreciate your time. You guys have been a fantastic group. And then I'll see if there's any questions.
Hey, Becci, we got a few questions here.
Perfect.
One, has the femur always been the best site to drill for IO in peds, or is this new?
It is new. So traditionally, we've always said, I'll get my baby back out. Maybe I'll even I'll just let you see my office person's messy office behind me. But so traditionally, we've done the tibia in children. And then sometimes we would do the humeral head, but less often because there's a lot of vessels and nerves there and the space isn't very big. And if we're not careful with our technique, we actually go through the growth plate, which as you grow, having your arms the same length is really important. So we try not to use this as often. But recently, it's really come into favor to do the femur for children. And it's because the bone is bigger, it'll be easier to infuse fluid, and you're more often to get blood back. So the technique for that is kind of similar to the tibia, and you just go a few of your fingers above their knee, and then you can't go right on top, right in the middle of the thigh because there's a tendon there. So if their leg moves or you move their leg, it might pop out. So you go just medial to that, kind of like in the tibia. And so that is our first choice, at least at Children's Nebraska in the ED. Also with IO placement, we say blue is for everybody. The pink needles, they kind of wiggle their way out because they're so short. So the right way that you would do that technique, so I'm going to hold a little leg up here. You're going to clean off your site. If you've got the EZ-IO gun, you're going to push the needle through the skin until it makes contact with the bone. You're going to squeeze your trigger, and as soon as you feel it go through the bone, you're going to release your trigger finger without moving your hand, and then remove the drill part. Even if there's still some of the needle hanging out, it will be in the right place, I promise. And then a tip for securement is to put a large bamboo mask over the site so that you can see your site and it's protected a little bit. So, because you're transferring them from cot to cot.
I like that. I would add, remember your scope depending on what sort of clinician or practitioner you are and your protocols with regard to
Absolutely.
such things, because everybody's different and every state's
Yes,
different.
anything I say is food for thought. I am not your boss.
Agreed. Agreed. Nor am I. Let's see. Do you notice anything relating to the pupils with clonidine?
Yes, they should be pinpoint. Thank you for asking.
Yeah. And then it says for Narcan administration, maybe do you notice a change in pupils when you give Narcan?
I honestly cannot answer that off the top of my head.
Yeah.
I think I've usually focused more on whether or not they're breathing better or not.
Mm-hmm. Yeah. If you could tell our ED staff in the audience tonight one thing that's the most important thing that they should know about treating pediatric patients, what would it be?
I would say be thorough and systematic and don't get distracted. You know, like in trauma, we say don't get distracted by the injury. In pediatrics, it's more don't get distracted by the story. Like Khan mentioned, you know, your heart's pounding and it's hard to keep your brain focused because it's somebody's child, their most precious person probably to them in the whole world. And sometimes that creates so much extra noise and it can make us miss things. So just be very, very systematic. And
Yeah.
do always listen to the families. They know their child better than anybody.
Mhm. Same question for pre-hospital clinicians. Most important thing, same, different?
I would say same things. Yeah, same things. But also for my pre-hospital folks, I always tell people walk swiftly and with purpose, no running. Take time to do what you're supposed to do and do it well, because doing something halfway doesn't help anybody, and getting there a few minutes faster doesn't help anybody if your interventions aren't done to the best of your ability.
Mhm. I like that. Does children's do sub-Q fluids?
We do sometimes. So I'm so glad I got him out of his box tonight. So we'll take a butterfly needle, not the one that's the hard needle, but the one that has a plastic catheter that can stay in. And you just pinch up a little bit of their fat kind of on their back, kind of like you would a dog. And you just put the needle just barely under the skin, infuse your bolus. This would not be a 5 to 10 minute bolus. This would be more like a 30-minute to an hour infusion. And they'll get like a kind of a puff up under their skin, but then that will be reabsorbed. We oftentimes here will put a little bit of, we call it Y days that you use if you have an IV infiltrate, because it helps open up the tissues so that they can accept the fluid better, absorb the fluid better. And then we just kind of let them get better. And then after they get that first bolus in, then maybe you have a better chance at finding a better vein someplace else. But we do try to get creative, and we don't do a lot of sub-Q rehydration, but we do a little bit of it. Well, if they are not vomiting, we might even try like an NG rehydration too, if we don't want to go to the place of an IO. But when you are doing your pediatric assessment triangle, sick, not sick, if you walk in and your patient is sick, then just go straight to an IO.
Mhm. Mhm. Let's see. I'm looking at questions. So if you're an EMS agency and you don't have a lot of money, which is, all of them.
Everybody.
Yeah. What would you say is the most important training to get, both for BLS and ALS services?
I think Khan's point about regular training, just every time you're doing something, throw in the pediatric part of it. If you have my my outreach group goes out. I know Vicki and I are like, yay, goes out and we'll do some scenario-based training. And so we do that with our larger local departments quarterly. And so I always tell them at the end of that, okay, so go back out to your trucks and think about this scenario that we did and look at your Breslow tape, look at your Peds bag and just relate it to that. You should all be in your bags probably a lot more often than you are, because the time to try to find something is not when you're on a call that's really stressing you out. And then I will give a plug to EMSC too. Use your state representatives. They have a lot of great resources and a lot of great education and connections. And so do use them to help you become more proficient as well. And please consider being pediatric ready as well.
I like that. What about training for hospital ED folks?
Same thing. Work with your state EMSC people or your pediatric resource centers. A lot of them have things that they'll do for you for free, virtually or in person. So just leverage your local resources. And then same thing, practice more often. You can have a really easy soft scenario. And so sometimes when I'm doing scenario teaching with people, if I have my teaching equipment with me, I won't let them have the Ambu bag, for example, unless they show me where theirs is. Or I won't let them place the IO unless they show me where theirs is. Because it's not just being able to say what you need, it's actually being able to find it in an ambulance or in a hospital where you don't do that very often.
Great. Here's a follow-up question to the sub-Q. What are the indications for using sub-Q fluids?
If you cannot get IV access, and if they are vomiting so you can't do NG rehydration, and if they are stable enough that you could give a slower bolus. If they're unstable at all where they need that true quick bolus, then you just need to do an IO.
What is the oldest age you have seen on shaken baby syndrome?
4.
Oh, golly.
Saw a 4-year-old with such severe injuries that when we took her to nuclear medicine, there was no blood flow above her shoulders. Yeah, see why I said I tried it? Like, Spider-Man's so fun because nobody ever asked me to talk about fun topics. Pediatrics are really hard.
What new technologies or tools have you integrated into your pediatric assessments recently?
My team is getting ready to implement ultrasounds to help with ET tube placements and chest tubes and some trauma evaluations, some different video glide scopes that we are just implementing here this week. And I apologize, the rep will probably be upset. I forget the name of it, but it has a special kind of blade on it, so it does not take much force at all, especially for those of you guys that intubate adults. You have to be really muscly to get their mouth open. And this one, and I have arthritis, so I'm kind of wimpy, and it was really easy for me to do the grown-up head. So yeah, I thought it was pretty impressive.
What is the value of NRP training for people taking care of babies?
That depends on who you are. So if you are a delivery center, of course, you should have NRP. Depending on the types of 911 calls you would get as an EMS agency, you could consider NRP. But there's also a really great resource out there called NRP for the non-neonatologist. And so I reference people to give that a go. Because it makes it super simple. We're beginning an initiative here at Children's Nebraska to help try to make a dent in the OB deserts that we have here in the Midwest. And so that is one of the resources that I recommend to people as we're starting to ramp up how we support people like that. So I know that this is a big regional EMS, from all of our 6 states. Nebraska in particular is in the top 5 of OB deserts, along with North and South Dakota for the whole nation. So in counties where there's not access to OB care or a maternal fetal medicine provider.
For both you and Con, what do you think of BLS for obstetrics and ALS for obstetrics as a course for medics or for hospital folks? I've been hearing a lot about BLSO lately.
Yeah, I mean, I think that, and I'll defer to Khan a little bit on this because he's more of the 911, not non-specialty person. But I would say if there is a potential that your BLS only service would have to deliver a baby at home or on the way to the hospital, there should be some basic training about that. I know in Nebraska, 87% of our EMS providers are volunteer BLS, and so I would like to think that in Nebraska, everybody has at least some sort of training. Luckily, if babies are born quickly and precipitatively outside the hospital, they're kind of slippery little suckers and they usually just kind of slide right out, not a whole bunch of complications. And so, I'll knock on something for anybody that doesn't have that experience here in the next few days. But I think it's reasonable to train on as many things as we can, especially in our large referral areas like those of us in the Midwest have.
Mm-hmm. Thoughts on that one, Con?
Yeah, I would agree. I think that there's a wide range of opportunities out there. I mean, not everybody can have access to OB mannequins and those types of things, but to reach out to your EMSC coordinator or your local hospital and set up some joint training, because often they're the ones that are actually the long-term provider for that OB patient. And so they're versed in the history, but it gives them a chance to understand, and maybe even just set up a time to come in and work with the hospital. Hey, we'd like to do some observation time in OB or any other specialty for that matter, but particularly around this topic, when there's deliveries expected, and if the mom will consent to it, that they can come in and just observe the delivery process. So doesn't cost the service anything. It's just time for the provider to go in, and also gets them in front of the staff, the physician, the nursing staff that's going to be receiving their patient when they bring them in.
Con, do your services do a lot of joint training with hospitals or law enforcement, school nurses?
Yeah, quite a bit actually. It runs in spurts, but we do on a regular basis try to interact with them on a variety of topics, whether it's trauma or active school threats or those types of things, in addition to peds and others.
Mm-hmm. I'm a huge fan personally of incorporating school nurses into your training and getting to know them and getting involved with them. They make things happen. They know all the kids in the community, and they can help hook you up with kids who have special healthcare needs and that kind of thing, so you can pre-plan with them. And they're good candidates for nurse exemption joining your service too. They're absolute heroes in my book. Well, thank you very much. You guys were great. We appreciate you so very much. Thank you for your time. Thanks everybody who came tonight.